Well, good afternoon, everybody. Come on, people. Just a couple hours before drink time. Really happy to be here. Thank you, everybody, for having us. This is a very exciting opportunity. The panel, we've met 3 times now on background. We've really prepared a lot. If you are familiar with 988, the new National Crisis Line, you have 4 esteemed experts on this stage who really have had their fingers on the pulse of what is happening with 988 and the impact it is having at a policy level, at a business level, and at a human level. And if you are curious about what is actually really happening for people across those spectrums, at the end of this hour, you're gonna have a real good sense of it. And before I say anything more, I would just like the panelists to introduce themselves. Hannah, why don't you just start real quick?
Sure. Hi, everyone. I'm Hannah Wesolowski. I am Chief Advocacy Officer at NAMI, the National Alliance on Mental Illness.
Good afternoon. I'm Tiffany Russell. I am the Chief Officer of Crisis and Justice Partnerships with SAMHSA's 988 Behavioral Health and Crisis Coordinating Team.
Good afternoon. Dan Gillison. I'm the CEO for NAMI, the National Alliance on Mental Illness.
Good afternoon. I'm Laura Evans, the Director of National and State Policy for Vibrant Emotional Health. Vibrant is the administrator of the 988 Suicide and Crisis Lifeline.
And real quick, let's just give a hand up for these fantastic panelists. Y'all don't know yet, but you're in for a treat. It's going to be some real good stuff. All right, thank you, and thanks for being here. And we're going to get it. We're kicked it off with Hannah and a very fast PowerPoint presentation.
I got a lot of pressure on me, folks. I got to get this through this fast. So I want to just set a little bit of the reality of what we deal with right now. In this country, 5,500 times a day, people with mental illness are booked into our nation's jails. 5,500 times a day. That means during this 1 hour that we are in here, 230 people with mental illness will be booked into jail. That's not right. We need to do something about that. We also lose 1 life to suicide every 11 minutes. And that means that we have 2 suicide attempts every minute and nearly 3,300 suicide attempts every day. We need to do more to help people in crisis. And that's really where the solution comes in. And that's why we're here talking about 988, hopefully a number you're all familiar with. This came about through bipartisan action from Congress. Unanimous consent this passed. Think about that. Something passed with unanimous consent in Congress. That is not something we can say very often these days. But the National Suicide Hotline Designation Act passed in the fall of 2020. It used the existing National Suicide Prevention Lifeline network that Laura will talk more about to provide this 988 resource, a place to go for anyone in mental health, substance use, or suicide crisis. And just a few months later, so that was in October, it signed into law. In December, fiscal year 2021 appropriations were set at $24 million. Now think about that. Do you think a number that is meant to help everyone in crisis, $24 million is going to get us there? Correct answer. No, it is not. What Congress did do was include a funding tool for states in that legislation. Paraphrasing here, but they essentially said that states could implement a small fee on phone bills to help fund crisis services. That's similar to what we see for 911 across the country today. If you all were to look at your phone bill, you would see probably about an average of $1 a bill per month to fund the 911 system. And in their infinite wisdom, Congress also, and probably some people in this room help with that too, Congress said that this is really to provide acute crisis services for anyone who contacts that 988 lifeline. So they really set out this vision that includes 3 things. 24/7 local crisis call centers, the ones answering those 988 calls, someone to talk to. Mobile crisis response teams, someone to respond, an alternative to law enforcement response. And then finally, crisis stabilization options, somewhere safe to go, a place that people in crisis can go and get the help that they need. At NAMI, we call this Reimagine Crisis Response because this is a transformational opportunity. It's a once-in-a-generation opportunity to fundamentally rethink how we help people in crisis. So since then, what's happened? Well, in 2022, I'm happy to say that federal funding for 988 grew by a factor of 10. So we have much more federal funding and hopefully more to come very soon. We also saw a few other things happen. One, in 2021, the American Rescue Plan Act said states could add an option in their Medicaid plan to cover mobile crisis response teams, those in-person response that provides an alternative to law enforcement. They also created a new grant program to fund mobile crisis teams that started in 2022. And then finally, earlier this year, SAMHSA gave out the first and hopefully many future grants to states. This is the first time states actually got funding to fund those 988 call centers. So to set those operations, $105 million went out to states across the country. Now this is a map that we have. You can see it at reimaginecrisis.org/map. But essentially, action is also happening across the country and states to set those standards. What kind of care is going to be available to a person in crisis? How are we going to fund it? And what oversight is going to be available? But I want to go back to one thing I mentioned before, that fee that Congress said states could implement. It's been 26 months since that legislation was signed into law, and 5 states have implemented that fee. That's money we're leaving on the table to help people in crisis. And every second matters when we talk about helping a person in crisis. More and more people are now aware of 988. This is some public opinion polling we've done. Right after the launch, about 14% of Americans were familiar or somewhat familiar with 988. But we have a lot more work to do, and that's what we're going to talk about today.
Thanks, Hannah. And so, just to give you guys a little bit of sense of what we're going to be doing. We're going to break up the panel portion of the conversation before we get to the audience questions into 3 buckets. We're going to be talking about funding and this funding that Hannah teed up. What's the future for funding for 988? We're going to be looking at standards around these services. You know, different places can do it in different ways. Well, what does that look like? What should standards be? Should there be standards? And also then how 911 and 988 interact, or the terrible word of interoperability. Finally, we're going to be talking about access. And so those are the 3 buckets. And what's really exciting about this panel is that we've got multiple perspectives here. We've got the perspective of a provider, we have the perspective of advocates, and we have the perspective of the federal government. So we really here have a kind of a 360 view on what is going on at very different levels. So it's really exciting, and again, very, very knowledgeable, kind, smart people. So with that said, Laura, before you answer the question of how you might add to Hannah's overview,
Sure.
Can you just give the audience a little bit of context? Vibrant. What is Vibrant, and what is Vibrant's role as it pertains to 988?
Sure. So Vibrant Emotional Health is a nonprofit mental health organization based in New York City that for over 50 years have been providing services for individuals who are living with a mental health condition and their families. So we are proud to also be a part of the Mental Health America Network. And we're really fortunate to have been the administrator of the National Suicide Prevention Lifeline, so the previous iteration, as well as the administrator moving forward for the 988 Suicide and Lifeline Crisis, the 988 Suicide and Crisis Lifeline. Very pleased to partner with SAMHSA and HHS to ensure that we are providing emotional support and crisis intervention services to anyone who may be experiencing a behavioral health emergency, as well as providing emotional support for their loved ones. So I just wanted to add a few, well, let me back up and see how many folks here are familiar with the structure of the 988 Suicide and Crisis Lifeline. Okay, great. So then I won't go into too much detail, but essentially you can reach a trained crisis counselor by calling or texting 988 or going to 988lifeline.org/chat and starting a chat session. For calls, those calls are routed to local crisis centers based on your telephone number, where they can again provide you that emotional support, crisis intervention, de-escalate from a crisis situation, and then, if appropriate, continue and connect you to other local resources for ongoing care. I want to share a few data points that I think will help set the stage for this transition. And the first one being 45%, and that represents the volume increase during that week of transition. So July 16th, 2022 was when our phone number changed to 988. And in that 1 week, compared to the week before, we had a 45% increase in people reaching out for support. And I think that is pretty stark, considering that we have not had a national marketing campaign. So I think that points to the fact that people may be struggling, dealing with the pandemic, or just other mental health concerns, that now that there is a 3-digit number that is easy to recall, they're reaching out for help. And that's what we want. And so not only have more people been reaching out, but we're able to serve more people. So if we look at September 2022 data, which is the most recent publicly available data, the Lifeline answered nearly 142,000 more calls, chats, and texts relative to September 2021. So I think that's a testament to some of the funding that Hannah mentioned and that SAMHSA and HHS has provided, that we have been able to add that much capacity within the system in that 1 year. So again, not only are more people calling, texting, and chatting and reaching out for help, but we're also getting to those contacts, and we're getting to them faster, significantly faster. So the average speed to answer for calls is about 36 seconds. And so we want to reduce the time that people are waiting. None of this is possible without the 210 approximately local crisis centers that are in the Lifeline network. The crisis centers and their crisis counselors are the heart of the network, and it's really imperative, as Hannah mentioned, that we ensure that they have the funding, sustainable funding they need to continue to do their work, providing crisis services and keep the people thriving in the community.
Thanks for that overview, Laura. So just a quick follow-up, and to hit this again for folks in the audience, 3 key numbers here: 210 centers doing this work, a 45% increase in calls from when 988 went live as it transitioned from the Suicide Lifeline to 988, and 142,000 more calls and chats in a week in September 2022 than in the same week in 2021. When you think about those numbers, Laura, what does that tell you? What sort of picture does it begin to paint? Is this like 988 infrastructure? Like, what is this to you?
Well, to me, this shows that this is something that should have happened a long time ago. Because, thank you. It is much easier to recall a 3-digit number and to have a parity with the physical health line and other public safety emergencies through 911. It's important that people know mental health is just as important. It says to me that even without a marketing campaign, that people are struggling and they want to support. And it also says that when you properly invest in mental health, you will see the return. So we are answering calls, more calls, chats, and texts, answering them faster, keeping people thriving, and helping them know that there's support, there's hope.
Thank you. And so, sticking with you for one more second, Laura, here, to talk about major trends and issues to resolve on implementation, what still needs to be done?
Sure, well, there's a lot of work to do. We know public safety, 911 has been around for over 50, 60 years almost. Yeah. So we are again at the start of the marathon. But I think for me, for Vibrant, it was really important pretty quickly after the Federal Hotline Designation Act passed, that Vibrant went into high gear and said, how can we support the local crisis centers? How can we support states? And we used funding to create 988 implementation grants Those of you who were at the summit last year may have heard from South Carolina and Pennsylvania and Harris in California talk about their experience with these 988 implementation grants. They were available to every state and territory that wanted one. In the end, we had 46 grants across the states and territories. And the goal was to convene stakeholders, right? Hannah outlined the core elements of a crisis continuum: someone to talk to, someone to respond, somewhere to go. But that looks different in every state based on that state's needs. And so the goal of the implementation grants was to have the state convene public safety, people with lived experience, loss survivors, attempt survivors, families, loved ones, the general public, to say, what is our current landscape? What are the gaps? Where do we need to go? What do we need to create? How can we ensure that we have enough capacity to answer the call, chats, and texts generated from our state? And so as we talk about those 210 crisis centers, some states may have one, and that's all they need to answer those calls, chats, and texts generated, right? Because it's a consolidated system. Some states may have a regional system or multiple crisis centers. So there's no one way to say, well, you have enough crisis centers. It's about the capacity. Do you have the capacity to answer those calls? So in addition to looking at that, the implementation grants also helped stakeholders decide, how are we going to fund this, right? Are we going to leverage that funding mechanism provided by Congress? Are we going to access community behavioral mental health grants from SAMHSA, ARPA funding? Like, what are we going to do? How are we going to pay for this? How are we going to ensure that we have mobile crisis teams built out? Do they already exist? Are they connected to the crisis centers? So those deliverables, those grants led to form the basis really for SAMHSA to have their state grants, but it really forced states to convene, to hear from people in the community, and to take a look at where they are, where they wanted to go, and how they were going to close those gaps. So Vibrant was pretty pleased to offer those grants to states and then to see SAMHSA continue that work, because there's a lot of work to do.
Right. The point is that I think, and just in yes or no, the point is that there's still lots of gaps.
Oh, there's still a lot of existing gaps in the crisis continuum. Yes, I will stop there.
and that sort of tees up this question to you, Hannah, around legislation. We were in the green room before this panel, and you were talking about, like, Congress right now is contemplating legislation. Can you give us a little bit of, give the crowd a bit of an update, please? What's pending legislation, would the pending legislation fill some of these gaps that Laura's talking about?
Yeah, some of the pending efforts are really about sustainability of the system. How are we going to fund it long-term? Who's paying for it? So the Senate Finance Committee, which oversees Medicare and Medicaid, among other things, has been looking at bipartisan mental health legislation. And in particular, they're looking at crisis services. And they propose that in the Medicare program, they cover mobile crisis response and crisis stabilization options. Now, think about that. That means that they don't necessarily cover that right now. If you have a cardiac event, your continuum of care that you need is going to be covered. That's not
if you're on Medicare.
If you're on Medicare or most insurance plans, that's not necessarily true for any mental health crisis care, and that's important because Medicare, private health insurance plans look at Medicare when they're making their decisions about what to cover. So that's one thing that's on the table. Funding for next year's on the table, and right now they're talking about $747 million for 988, the office at SAMHSA, as well as resources. And remember, $24 million was what we had in December of 2020. So that's huge growth, but there's still a lot more to be done. But really, this is all about sustainability. How do we make sure that this is a system that's going to be available to everyone, everywhere, for perpetuity?
And again, this is within the context of funding. And one of when this passed Congress, please correct me if I'm wrong, my understanding, having covered this as a reporter, is that when Congress passed legislation authorizing 988, the idea was, sure, there's a little teeny bit of seed funding from the federal government, but really they're kind of kicking this to the states. states were authorized, and as you pointed out in your presentation, the states were authorized to tack on these cell phone fees or whatever, and that would be the primary funding. But you're saying this Congress right now, before the new Congress starts in January, is actually looking at making a significant investment.
Yeah, $747 million is not going to cover all of our needs to build this system, though. This is a federal network that's operated by states and localities. So it's really their shared responsibility there. The federal government can help set standards and provide some of that seed funding, but states also play a huge role, and they have to work together to make these services possible.
Dan G., going to you for a second here. So even if 988 were to be paid for, which we know it's not going to be any time in short order here, what are about the limitations of care after a crisis, the lack of brick and mortar spaces?
Yeah, it's a huge opportunity. It's a huge need. If you think about 988 and you think about the launch, we're 150 days in. So if you think about 150 days in, we're at the embryonic or infancy stages if you're thinking about a newborn. So the brick and mortar is at the end of that continuum, if you will. And Dan, coming back to your question from the standpoint, if you look at what's happened over the last 2 years with COVID, we've got a lot of brick and mortar around these United States that is empty because workforces have gone virtual. Well, we talk about reimagined crisis response. Reimagine if we repurpose that brick and mortar and actually created it to be crisis stabilization centers. The brick and mortar exists in terms of real estate around these United States that is empty right now. And yes, that is an area that if you look and you did a gap analysis, it doesn't exist, but it is available to exist. The other thing I wanted to mention before we go to the next question is that map that Hannah showed you is actually what we call a heat map. So it's a real-time information where you can actually take your cursor and put it over the map, and you can see what's going on in any particular state. So as you look to see in the state in which you live and work, what's going on in your state to empower and to engage and to operationalize 988, you'll get data points in terms of what's happening legislatively. So thank you. But brick and mortar is critically important to this. And the last thing I want to say is this, is that the other part of this is that before COVID, we talked about the fragmented mental health system. 988 gives us a chance to actually create a robust mental health system. Thanks.
Well, thanks, Dan. And so, Laura, you've made this point in some of the background calls. When we think about funding, it can get kind of a little spreadsheety, a little line item like where, well, what's Congress paying? What are these fees? What's happening in the state level? And in some of our background calls, you challenged the panel to zoom out a little bit, to look bigger. What is the point that you're making there?
Well, the point I want to make there is that we are all paying for this. Whether or not, we're paying a 988 fee, we're still paying for it. If we're not properly resourcing 988 Lifeline, which has the opportunity to divert from law enforcement and inappropriate hospitalizations, then we're just going to pay for it on the back end when we have to incarcerate those individuals. And I say have to because that's the option that they have right now, because there is, we haven't created the systems that should be there. So we're going to pay for it in terms of hospitalizations and unpaid for care that has to be written off. We're going to pay for it in the incarceration every day. We're going to pay for it in other venues. And so we can choose to pay for it up front and see a return on investment and keep people thriving and have more opportunity and options for individuals that I know Karis has talked to you about before, not limiting folks who live with serious mental illness. Or we can continue what's been done and we pay for it through jails and other ways that we know don't work. And so my challenge is to say, well, if we're paying for it either way, why don't we pay for it in a way that actually is supportive for individuals who live with mental illness? How about we resource the crisis centers who are doing this work to keep people thriving? How about we resource crisis stabilization and providers to stay in this field and not burn out? We're going to pay for it either way, so we should try a way that is going to help individuals.
And thank you, Laura. One of the things, Dan, that I try to insist on at Tradeoffs, at the podcast I work at, is I asked the reporter producers to really kind of come with numbers. And in some of our background calls, I said to you, I need some numbers, Dan. Because part of this, right, is given the crowd, you guys have all this amazing expertise. Again, you have your fingers on the pulse. What is actually happening out there in the world as it pertains to 988? And I said, Dan, can you come and educate us on the states? What do we know is actually happening in 988 at the state level right now?
Yeah, so when the reporter asks, you want to make sure that you have all the data points. So thank you, Dan G. So to this Dan G, what's happening and what has happened is, and to make sure that I'm accurate, there's really 4 critical things that I'd like you all to know that have happened to date. 5 states have enacted the 988 telecom fees. Why that's important is because that's sustainable revenue, and that's a build. 4 states have passed 988 legislation that strengthens either the commercial or Medicaid coverage of crisis services. California and New Jersey have really strengthened their commercial insurance, and Utah and West Virginia, Medicaid. 7 states have created advisory boards, and that's important because where NAMI is really looking at making sure that on these advisory boards, there's lived experience, and it also is representative of equity. So these advisory boards are critical, and only 7 states have created those boards year to date, or 988 to date. And then 4 states have required a study of 988 and broader crisis care systems. I love that we have states that have required a study, but it gives me anxiousness from the standpoint, oh boy, that's going to take another 3 to 4 years. We don't have time for that. So while that's noble that you've created a study, I need you to step up and do something sooner. So that's, and the biggest one is that 30 states have passed appropriations for at least one of the core crisis services. That's either the call centers, the mobile crisis teams, and or crisis stabilization. So we have 30 states that have passed appropriations. So it's how do we really move that to the next step in terms of what that can look like for a continuum of care versus just one component. But yeah, that's a metric.
Can you? I warned you I was going to do this. Can you follow? I didn't understand it when you said that in the green room. I don't understand when you're saying it right now on the stage. What do you mean? What do you mean when you say, you know, they've passed 1 of 3? What's the point here? 30 states have done something. Is that?
Yeah, 30 states have done something. Looking at appropriations for, if you looked at it as lanes or areas, and when you talk about a continuum of care, you're talking about touch points from the inception of a situation too. So you heard us talk about someone to answer the call and someone to respond and a place to go. So what that is that they have passed appropriations for one element, either the call center or the mobile crisis part of it or the crisis stabilization centers.
Thank you. Mm-hmm. Appreciate that. Mm-hmm. Very clear. Tiffany, we're coming to you. You got the nicest outfit on, hands down. It's been a long time. Can you remind us what it is? You work for SAMHSA. You work for the federal government. What is SAMHSA's role? And before I ask you actually the question, just help the audience understand how you sit here. What is SAMHSA's role when it comes to 988, please?
As an anecdote, SAMHSA is the parent and Vibrant is the babysitter, and they are managing and making sure that everything is going as it should. But we are a partner to Vibrant. We are the federal agency that manages the 988 crisis hotline, and we support it through policy changes and funding. We have an office dedicated to the 988 crisis line. But we work very closely with our administrator, Vibrant Emotional Health, and their 210 centers to ensure that there are people there to answer the phones when someone is in need.
And one final zoom out question. What is SAMHSA? Why does SAMHSA exist in the federal government? Again, just to help give people this context.
Wow, okay.
He didn't tell you that one was coming.
That was not discussed in the green room.
Oh, excuse me, let me move back a little bit.
Well, SAMHSA is the Substance Abuse Mental Health Services Administration.
Pop quiz.
So basically, we are the agency. We have a lot of federal agencies that handle different areas, but basically making sure that substance abuse and mental health services are available to all Americans.
And so when it comes, thank you for all that context. I appreciate it, at least. When it comes to the funding and SAMHSA's future funding goals, can you just sketch that out for us, please?
Well, I think it's really important to know that SAMHSA has a 5-year plan that does not end with just 988. Like, this is the beginning for the crisis care continuum transformation that SAMHSA is thinking about. And so we have talked multiple times about the 3 areas: someone to call, someone to respond, and a safe place to help. 988 was part of that someone to call. And our goal there is to ensure that at least 90% of all of the calls that come into the crisis line can be answered and responded to within the state by 2023. But additionally, we're also thinking about who is coming to respond to those calls after they have reached out to 988. Thinking about mobile crisis teams and wanting to ensure that at least 80% that we have access, at least 80% of all Americans have access to a mobile crisis team, mobile crisis services by 2025. And then building on top of that, that we have a safe place to take them that does not include the jail or emergency rooms, which is the case as it stands right now. We want to ensure that there is at least 80% of Americans have access to that by 2027. So we did not stop with just the 988 implementation. We're not sitting in our offices like, whew, that's done. Like, what's next? We're really thinking about how do you build out the beginning, because this is just really the entryway to getting into those services that everyone needs. And it's an easy way. You can call, you can text, you can chat. It's really just that entry point to getting someone into crisis care services.
And when it comes to the funding piece, how is SAMHSA thinking about funding over the course of these next 4 or 5 years?
We need it. We're asking for it. I think, we think about our funding very broadly. Again, it's more than just the 988 services. We're thinking about the mobile crisis and what needs to go there, the funding that needs to go into our crisis stabilization centers. But we're also thinking about, while we're developing these services, the funding that is needed to make sure that we do not have disparities, that there is equal and equitable access to those services. And so ensuring that the services we provide are equitable to all folks. So we have an office that focuses specifically on behavioral health equity. When you're thinking about developing more crisis services, making sure you have these partners at the table when we're developing that. But I mean, there are different funds of streams of funding that we are considering, and it's more than just providing it for the service. Like, we're thinking about all of those other parts of that the workforce, the technology, the training, all of that is part of what SAMHSA does on a regular basis when they're thinking about those services.
And I mean this respectfully. Like, I know you work for the federal government here, and there are only certain types of things you're able to say, and if you can't answer this question, that's fine. Do you sense, like, when Laura talks about these numbers, and Dan G talks about some of the state actions, does that tell the administration in Washington, you know what, there's something here. We need to increase the momentum and get some more dollars? Is that sort of alive and well within the administration?
Absolutely. I mean, when we think about this, I mean, the numbers were very clear in the presentation when we first started. We had $24 million to start with this effort. In 3 years to get it up and running. And now we are well past that number. I think a lot of the bipartisan agreement on this particular topic, this particular issue, being that this is like the first time that you're seeing states really involved and bringing everyone to the table for this implementation, shows the effort, the coordinated effort, but also it shows the commitment that everyone has around this particular topic. And that's not something we've seen before. So I definitely feel like those combination of things definitely led to an increase in funding that we have not seen in other efforts or initiatives.
Very good. Thank you so much for that. And so let's move on to this next question about how 988 is working with 911. This is the interoperability that we were talking about earlier at the top of the panel. Tiffany, staying with you, can you talk a little bit about this 911 988 playbook? What is that, and what's going on with it?
So it's really interesting that last time I was here, I didn't work for SAMHSA. I wasn't part of the 988 team. I was actually with Pew Charitable Trust, and I was looking really closely at the 911 call centers and thinking about how they're responding to behavioral health response, and thinking about the 5,700 call centers across the country that handle over 240 million 911 calls per year. A lot of those calls were related to behavioral health crisis response. Do we know what that number is? No. Do we have a percentage of what that number is? No. Do we know how those calls ended, how they were handled, what's the disposition, who was dispatched? We don't. But because we do know that the majority of those behavioral health calls were going to 911, SAMHSA understood and knew very early on that it had to work very closely with 911 in order for 988 to be successful. And so one of the things is that they did is they started out with having convenings with subject matter expertise. A lot of the folks that are in this room right now were part of those convenings that came and sat around the table with individuals with lived experience, and told us what they needed to have in order to make this work. These are the resources and the tools that I need. You have to give them to me in order to make this collaboration work. And the guidelines and the standardization protocols, the stakeholders that needed to be a part of the conversation, all of that is included in this guidebook that was put together with the help of subject matter experts and a lot of the folks in this room, behavioral health providers, that had to come together and say, for 911 call centers, in order to work with 988, here are the basics. This is basically what 988 is. We have the basic understanding of what 911 is. And here is how you can work together, or how you should work together, in order to ensure an easy transfer of calls, to ensure that the person that is seeking help has the appropriate response at their time of need. And so if it means that 911 needs to transfer over to 988 or vice versa, they have the guidelines available to them in this playbook that SAMHSA developed to help them make that transition. In addition to the playbook, SAMHSA also started a policy academy to work with 5 states that are kind of considered to be early adapters or early innovators in that sense of already wanting to work around 988 and 911. And so we brought those 5 states together, California, Colorado, Georgia, Maine, Minnesota, and put them in a room along with more subject matter experts and said, tell us what you need, tell us what we need to provide to you, what does that look like, and how can we be supportive of you in this effort? And so they worked well into the implementation of 988 to really think through the playbook itself, but also the policy changes that are necessary and that were needed so that SAMHSA could really support that collaboration. I think moving forward, there is still a lot of work that needs to be done because there is a lot of distrust between 911 call centers and the 988 centers because of one major issue, which is liability. They are afraid. They are a risk-adverse entity. And so they are constantly thinking about, am I going to be sued if I send a call over to the 988 center and then something tragic happens? And so those are some of the major concerns that are still out there that we at SAMHSA are thinking through and wanting to work through our partners, not only our federal partners, but external partners, law enforcement, as well as 911 call centers, and thinking about how can we address that. Is it a case law review? Is it a white paper? Do you basically need us to write a policy that says it is okay for you to do this? But to also think about what are the protocols and procedures that we should help you think through when dealing with your workforce and your technology and making that transition a lot better.
Thank you. And real quick, can somebody on the panel, please, just real quick, like in 30 seconds, give an anecdote, real or made up, of why does just as an example.
Are you saying I was long-winded?
Time is ticking.
You done?
Why does 911 and 988 need to collaborate? What's an example a story that illustrates why interoperability is actually essential?
Well, I can start, and others feel free to join in.
But super tight.
Well, yes, and so if I have to keep it super tight, it's about getting the right intervention at the right time. So there will be times where someone needs to just talk to someone. They need that emotional support, and that is when you should call 988, right? You're in a behavioral health emergency, you need to talk to someone. Mm-hmm. But if a person has, let's say, I don't know, overdose on the bottle of pills and they've drank the bottle of Jack and all those things, calling 911 first to get the EMS, right, is important. Because at that point, talking to someone isn't going to reverse their overdose. You need to get EMS out there or activate a mobile crisis team that has Narcan, or, so to me, that's just the right intervention at the right time. These two systems cannot replace each other. They must work together as appropriate to ensure that we are saving and helping people.
Thank you, that's very helpful. And then Hannah, to you, one of the big questions, one of the big challenges here is like, okay, 988, from a consumer standpoint, if you are in a mental crisis or an emotional crisis or what have you, behavioral health crisis, you might be prone to call a social service agency, but there's some privacy concerns here. There's some law enforcement concerns. Can you speak to that quickly?
Yeah, I mean, I think many of us in this room who have been heavily involved in this space know that there's a lot of real trauma out there, what people's real experience has been. They've called for help for themselves or their loved one, and they have been handcuffed, they have been taken to jail, they have been stuck in an emergency room for days, in some cases longer than that. So there's real trauma and fear. And so as we think this through, the potential to collect information to better route calls, but also to dispatch life-saving services, which is a larger issue in what we do and how we do that in the future with 988, is a real challenge to work through. How are people's data going to be used? Somebody's in crisis. Can that data be used against them for employment or for custody or for a whole host of things? And that's because there's been so much trauma experienced by so many of us and so many families.
That's great. Thank you, all of you guys, for your answers, all of the answers. So we're going to turn to you all now for questions, and I believe there are 2 mics set up. So please, when you come, just be cognizant of introducing yourself and be succinct with your question so we can make sure lots of people have opportunity to ask. Thank you.
This is John Petrola with Meadows Mental Health Policy Institute, and I have a question for anyone on the panel. How essential is it that the states fund this in the way Congress contemplated? Because on the one side, it's a great theory. On the other side, it sounds like some of the cost shifts Congress historically has done. So is getting from 5 states to 30 or 40 essential for the ultimate success of this, or are there alternative routes to get beyond the original mechanism Congress established?
Thank you.
I'll jump in. Is it essential? No, there are other ways that you can fund this. But what we do know is that historically, when there are budget cuts, when there's a recession, mental health is the first thing on the chopping block. And the thing about these fees is it's sustainable funding. You don't have to go back to the state legislature year after year to get it. You don't have to go to Congress every year to get funding. It provides a sustainable funding stream. In and of itself, it's not going to fund the whole system. We need insurance coverage of this. We need other funding streams, but it's a really important element to make sure that we will have these services for years to come. And so it becomes much harder to do that when you're going to your state legislature year after year.
And if I could add just onto that, because it's such a great point, and the FCC collects information about 911 fees every year. The new report should be posted this December, but I'd just like to go in and check, and you can see what each state has and what they've generated. And 911 fees across the country and the territories generates over $3 billion annually just for that 911 system. And we've heard from our public safety partners that even that's not enough. So when we talk about the federal government thinking or considering about 747 million, sure, that's a great improvement over 24 and even the 7 we were at before. But we need to be at the 3 billion and plus if we're really talking about parity.
Hi, Travis Atkinson with TBD Solutions and the Crisis Residential Association. Just a quick foot stomp first from what Hannah said, which is that if you have commercial health insurance or Medicare, you have access to less of a behavioral health crisis continuum benefit than you do if you have Medicaid or no insurance. That needs to change. That needs to be a part of the parity conversation. My question for anyone on the panel is, there's been a lot of discussion about this three-pronged approach to crisis services, and specifically that third prong is of particular interest to me. At these crisis stabilization centers coming in in 2027. I believe many people attending this summit have an agreed upon belief that we want to keep people out of more restrictive settings and in the least restrictive, least intensive settings possible. When these services say they will accept anyone, that means they often have to be locked and secured, which means you're putting people who don't need to be in locked settings into locked settings in order to treat them for usually up to 23 hours. I'm curious if you could help us to understand a service that does currently not have much research behind it compared to the other options in the crisis continuum, why that is so important, and why we're not looking at less restrictive settings such as peer respites and crisis residential services before we get to that level where people are locked.
I think we're talking about a portfolio. We keep labeling it crisis stabilization centers, but we're looking at a portfolio of offerings. I guess the place to take you is to looking at the fact that we don't want the jails to be the ipso facto mental health hospitals, and we're looking for different types of residential places and residential systems and crisis stabilization centers and all the different elements in the whole portfolio of what we could offer. So we probably need to look at that labeling, but we are looking at a whole portfolio of what would be at that end point in terms of, but what we do know is that what we've been doing is not working in terms of the jails, and that is right now the volume, and we need to invert that and get a volume in another way. And your point is well taken in terms of that. So thank you.
Hello, my name is Oyewumi Oyeni, and I'm a student reporter with YMG. And my question was, what major change would you like to see nationally or in Philly to improve access to mental health crisis services, especially when it comes to like disparities for minorities and other BIPOC individuals?
Question. Anyone want to jump in?
I think, first of all, thank you. As a student and as a young person, we need your voice, and we're so glad that you're here. So thank you. As we look at the adoption or the access, it's critically important that we first listen to you, and then we look at, like all of us in here, we make up a whole tapestry of different organizations that do work in this space. And what we need to do is to make sure that we're working together, and that there is, I think as we were speaking to the director, the CEO president of the art PAFA, if you will, Philadelphia Art Institute, if you will, what he was saying is that it's about collaboration. And that's what we need to make sure that there's collaboration, and also there's marketing, that our young people and all people know what the services are, how to access the services, and where to go get the services. So answering your question, I think it's better marketing, better communication, and better collaboration. And it's young people like you taking the message back to the communities, including our HBCUs, our historically black colleges and universities, of which we're working with several, and Cheney State is one here. So we need to make sure that we bring that audience to this kind of a room, and making sure that those young people also are building student mental health consortiums, that they're talking about resources, and that we're also articulating to them what those resources are.
Thank you.
I think I'm up next. Ken Zimmerman, CEO of Fountain House. It's good to see many friends, and Tiffany, you won't be too surprised by this question. First of all, thanks for all the work you're doing, right? It took 911 a decade to get up and running. And I think, Dan, to your point, this is very much the very early stages of 988, and we need it to succeed. At the same time, and I guess this question is informed by what we've learned from homelessness policy and the dangers of creating a standalone crisis system that is unrelated to everything else that is needed to address the core underlying issues. How do you think about some of the really important things that aren't necessarily embedded in the three-part system? I think about prevention, for example, as something we obviously want to reduce the amount of crisis that's occurring to begin with. We want to understand if there are people who are repeating their calls, what's going on with that, and how do we build that in? And then at the back end, how do we diminish the amount of recycling that occurs, the postvention side of it? And I'd love your thoughts as we build out on what needs to happen right now, that we're not just building a faulty system, as has frequently occurred in the homeless shelter system, that we then need to, transform down the line.
But before you guys you threw a lot of very provocative, interesting things out there. But can you just for the sake of time, can just distill down, like, what's the essence or what's a nub of one of the questions you're really getting at?
Sure. Well, let me ask the one. How do we ensure that prevention of crisis is built into the substantial efforts that are taking place, as opposed to just creating a crisis system that assumes the level of crisis continues?
I look at this as it's an opportunity we have with 988, right? We don't want any person to get to the point of crisis. We want to help them far before that. I think as we build out the prongs of a crisis continuum of care, working towards post-crisis as well as pre-crisis, how are we helping people and building up those services so that the 988 and crisis response system is a safety net, but it's only a safety net and it's not the basis of the system. I think this gives us a real opportunity because there's momentum to build on this and then expand further, because those are such important points. We need to make sure that people who come into any crisis facility have connection to additional social services, because we don't want them cycling. But we also need to connect them to those services far earlier, which may help prevent that crisis from ever occurring. So it's such an important point. I think about it a lot, and I think this is a jumping off point for all of us.
Yeah, Ken, the other part there, thank you, Hannah. The other part there is that with our federal partners, Health and Human Services, SAMHSA, and other agencies, they are absolutely addressing the continuum of care long before we get to this reactionary point. What do I mean by that is, you heard me use this word portfolio earlier as we were talking about SAMHSA. They've got a portfolio where they're looking at early intervention. And a lot of times in our space, we get to addressing the symptom. We got to go back up to actually getting to the root cause. And some of that, as Hannah talked about, she led off with trauma. So what you see with these agencies, Ken, is that they're really trying to get to, SAMHSA is doing work with very young people, youth and young adults. They're doing work with different sectors in terms of BIPOC communities and other communities, and really have built out a whole strategic plan, if you will, that is trying to get to the early intervention and really addressing the trauma early before we get to the point of the reaction to having to place that call. So that is a part of that whole body of work that Health and Human Services are doing, even with educators and in school systems across the United States. So there's a lot of work going on to get up front, to go upstream before you get to this.
And Ken, if I could add too, part of the planning grant was to ensure there was that coordination, right? Because oftentimes the state wasn't aware of who the crisis centers were in their state and who was answering these calls and if they were connected to other services. And so with that planning grant, it facilitated that introduction to who are the people answering 988 contacts in your state. What do they need? How can we close those gaps? How can we coordinate a system so that we are not losing anyone? How can we ensure that those crisis centers which often do other education and training in the community, have robust resource referral databases for those frequent callers so that we can connect them to ongoing care, because this is not a service where we, provide therapy ongoing. This is crisis intervention, and so we need to connect folks to that ongoing care. And as it relates to this conference and diverting from the criminal justice system, I want to talk just very briefly, but Dr. Amy Watson is in the audience, and she could probably speak to this better than I can. This concept of intercept zero, so not even waiting for folks to to interface with law enforcement, but moving further up so that we are preventing interfacing with criminal justice, trying to prevent crisis, and if people do have crisis, connecting them to ongoing care.
And we have time for just one final super short, quick, tight question.
It's a simple question. Jonah Cunningham, the National Association of County Behavioral Health and Developmental Disabilities Directors. It's a shorter question than my title. Is 988 a public good or is it an extension of the healthcare system?
Ooh.
Because it relates to the financing.
So much for a short question. That's good. Thanks, dude. Great question, though. Great question. Like, we need the wine for that one.
Yeah.
You said,
I'm looking at.
I mean, I think that it's a public good, something that we all deserve access to.
Yeah.
This needs to be there for everyone. I think it has connections to the healthcare system, but in terms of a resource that everyone can access, it needs to be available for everyone no matter what. And frankly, I have a 3-year-old. I hope she grows up not remembering a time when this didn't exist. Just like many of us in the room, really don't remember 911 not being a resource. This needs to be something that's available for everyone.
Seems like a fantastic question for people to continue talking about. No, I'm serious. Over the course, not just being a time manager here. Over the course of these 2.5 days, that's a fantastic question. What should it be? What should it look like? As a health policy reporter, I totally get it. I know we've got to go. Okay, so 30 seconds, people. You guys get your op-ed moments. Go ahead, Hannah. What do you want to say? What do you want to tell this group?
We can't take our foot off the gas. This is going to require all of us a sustained effort, and I think it's common for us to want to move on to the next thing, but we have a real opportunity here. It's going to take all of us. There's a lot of work to be done, a lot of great questions pointing out some of the holes in this that still need to be worked out, but it's going to take all of us, and I think we can get there.
Tiffany.
I think I would say that 988 is the moment. It's the moment we're all thinking about right now, but I hope that we take the momentum behind this moment to continue to build and improve culturally competent, person-centered access, services for everyone involved, and that we come together not just as a federal partner, nonprofit organizations, but we really think about the local people that the services are affecting, that we really work hand in hand with them in creating a system that works for everyone.
Dan?
It's always about scaling, and in scaling you always look for a model where it's being done well. And the state of Washington, as a point of information, is doing this very well from the standpoint of being an early adopter, and they've taken a lot of actions to create sustainable funding. Highest 988 fee in the country at 40 cents. Also in a separate bill, the state clarified that mental health crisis care is considered as emergency care and therefore not subject to certain harmful insurance practices such as prior authorization and out-of-network charges. And that is about leadership, and Representative Orwell and her leadership, as well as our executive director for NAMI Washington, in terms of their work in terms of this, and Lauren Simons, who's here. So the net is that this is about leadership, tone, and execution. The other thing I want to say is that I think this is for the public good, and I would say it's both and I would say that if you think about Miles Hall, and his mother, Ton Hall, is here, and his sister, Alexis Hall, is here, and if 988 existed when Miles was with us, the outcome may have been different. So I think it's for the public good.
Laura?
Yeah, I'll say yes. I agree with Dan and the others. It's both and I just want to leave with the sense that these crisis centers in the Lifeline Network are truly local. So I would implore everyone to get to know their crisis centers, volunteer, help them. You know, as Hannah mentioned, there are these bills at the state level, at the federal level that need pushing. They need to know that this is important, and it's not just important right now because this is the hot topic, but it's important in perpetuity, that we need to have sustainability, and that we again need to move further upstream so we can help prevent crisis. But those crisis centers, those crisis counselors, they are the lifeblood, day in and day out, taking these calls, chats, and texts. And we need to make sure that we're supporting them. And then I'll also leave with, if you or anyone that you know is struggling, please feel free to call or text 988 or chat at 988lifeline.org/chat. That resource is available for you.
Let's give it up for this great panel.